Salam alaikum. Hello and welcome to the Pain Medication Proper Use versus Misuse webinar on the 27th of September 2020. The time is 7 p.m. here in the UAE, and I would like to welcome you all from wherever you are attending from. My name is Gerard Moore. I am the webinar support manager for today. If you have any technical issues, you can press the admin only button on the chat bar and I will receive your private messages. If you have any video or audio problems, you can press the red reconnect button located at the top of your screen. The webinar is being recorded today and will be accessible for the next 4 days. We'd like to thank SSMC and Saha for their endorsement and to Pfizer Upjohn for their continued support of this webinar. I will now hand you over to our chairman and moderator for today, Dr. Ahmed Shatila, consultant neurologist at SSMC Abu Dhabi. Dr. Ahmed, the floor is yours.
Thank you, Gerard. First of all, welcome everybody to our third pain webinar on pain medications, proper use versus misuse. Today, I'm pleased to present Dr. Ammar Salti. He is a pain consultant at Cleveland Clinic, Abu Dhabi, and he's going to talk to us today about pain medications, proper use versus misuse. As always, we'd like to thank, first of all, the audience for taking time to attend these meetings because these webinars could not occur without your support. I would like to thank Pfizer Upjohn for sponsoring the event. I would like to thank SSMC for hosting the event and Focus Gold for organizing the event. So without further ado, I would like to present Dr. Ammar. The floor is yours, sir.
Thank you very much. It's a great pleasure. Thank you, Dr. Ahmed, for kind words. And I'm really glad to be part of your webinar series. I know this is the trend nowadays. Unfortunately, we don't have a direct contact with our attendees and our colleagues to interact and to talk lively. It's a pleasure to be part of this meeting, especially this pain medication issue and proper use versus misuse. So, Assalamu alaikum for those who are joining us as patients. I'm going to try to make it as interactive as possible and give you some ideas and some thoughts about this problem of medication, chronic pain medication. As Dr. Ahmed said, I work in Cleveland Clinic, Abu Dhabi. On the left side, you have a nice picture of the Cleveland Clinic. And on the right side is my university where I grew up in Paris, Université René Descartes. And René Descartes is the first one in the 19th century who described the pain pathways. So I'm going to start with the pain pathways. I will finish with pain pathways. I will see my last slide later. So when I started thinking about this topic and this, this presentation, it was for me a result of many years of thinking about how do we deal with this issue? How do we introduce to our population and to our general population the way to deal with chronic pain medications? And sometimes it's not easy. It's very challenging, and sometimes it's even difficult, very difficult, with some issues with some patients, and we'll talk about this later. I have no disclosure. I'm just a founder of the Gulf Pain School, which is an educational body that helps pain physicians to learn about pain and procedures. And I'm the president of the Gulf Pain Society for 4 years now. I'm going to start by a new definition, because when we talk about pain medication, for 40 years, 4 decades, we had definition for the pain, and pain has been described and introduced in the 1979 by Mirsky and colleague telling us that pain is unpleasant, sensory and emotional experience. And recently we had an update on that. Last March, we have an update on this definition, and they focused mainly on the other aspect of the definition. The other aspect is the way how pain is considered as a personal experience that is influenced, and this is a very important word, influenced by lots of elements, biological, psychological, and social factors. And in our topic today, when we talk about pain medication, these factors will be having a lot of influence on how patients will deal with their medications, chronic pain medications. And the other sticky notes for this definition is that although pain usually serves with adaptation and we adapt regarding pain, we have many factors that will lead to some difficulty in adaptation, in being compliant with our pain feelings. And this is another important point when we have patients with chronic pain medications. We all know that pain has a triad, biosocial, psychosocial model, and this is the essence and this is the basis of the treatment for chronic pain patients. We know that we need to deal with interdisciplinary management for that. We need to have collaboration and coordination between different disciplines, and we need to think mainly about the function. And the function, when you have a pain medication, we need first think about the function, how these medication will help with functioning and how they will lead with a very good quality of life. So this is an important concept also to consider. Chronic pain is a disease. We know that it's a magma of influences between the depression, insomnia. We start having negative beliefs when we are a chronic pain patient. We start to be medically dependent and socially deprived. So many influences, and we need to try to decorticate this magma of elements and leading to better understanding of how we deal with this chronic pain. And pain changes also our brain functions. We know that since many years that pain can lead to difficulty in sleeping, lack of energy, drowsiness, depression, anxiety, poor appetite, and poor sleep, as I said. So lots of influences, and we need to think and to take care of these elements when we deal with chronic pain patients. So chronic pain medication, we know that chronic pain population is huge and important, and we need to try to find out how we can adapt our way of management when we deal with this population. We know that many patients, they are not very compliant. The adherence for chronic pain medication is a problem sometimes. And you can see here in this slide that the rate for compliance or non-adherence varies a lot, from 36 to 81% of overall non-adherence for medications. The overuse is from 3 to 75%, and the misuse can reach 32% of these patients. So we need to always put in mind that we can have some problem in dealing with the adherence. How do we deal with that? It's usually simple, and the acronym of simple means we need to simplify the regimen. When I see in the clinic patients with 10 medications and they need to adapt the whole day to get their medications, this is not easy for adherence. Impart the knowledge, share the knowledge with the patients, trying to explain the mechanism of these medications, how we can simplify them, how we can understand why these medications are acting this way. Of course, when we discuss with patients, we need to modify their beliefs about the medication, provide the communication and trust, and then evaluate the adherence with time. So we need to, when we start any pain medication, we need to present always things simply. We need to help patients to understand and to be more adherent to the medications. And as I said, the total chronic pain population, this is a sort of classification of these patients. Some of them will be having some aberrant medication taking behaviors, and we'll see some of the example on that. Some medications, some patients prescribed chronic pain medication will have drug misuse, and they will use them differently. And a very small population, hopefully very small, will get to the addiction part, the abuse or the dependence. So لحد الآن إن شاء الله تكونوا تبعتوا إنه الموضوع سهل، بس كيف نوصل المعلومة للمريض لما نشوفه في عيادة الألم، هذه أهم نقطة في محاولة جعل الموضوع سهل للمريض، وجعل المريض يكون مهتم بالمرض تبعه، بالألم تبعه، وبالأدوية الألم اللي هي بعض الأحيان تكون مش سهلة لأنه الواحد يتعامل معها. شو النتائج أو شو الجولز in the pain management، شو الأشياء اللي احنا نصبوا إليها. We need to involve the patient in the decision-making process. They need to be part of the decision, and we need to agree on realistic treatment goal behavior and before starting any treatment plan. Chronic pain is not easy. Sometimes patients, they come with very high expectation، تطلعاتهم إنه الألم يخف نهائيا، يختفي 100%. هذه من الأشياء الصعبة. فلازم نلاقي البالانس بين شو، بين البين ريليف، إنه المريض يحس ببعض الراحة من الألم، وخاصة improved function. أشياء إنه to improve function is very, very important part of it. At the same time, we need to think about minimizing the adverse effects. Every medication has adverse effects, and we need to explain to the patient that this is the balance between this positive and negative elements for chronic pain management. لازم المريض يقتنع، وقناعة المريض بأنه في بعض الحالات ممكن يكون في آثار جانبية اللي هي المفروض تكون تحت السيطرة، under control. Whenever these adverse events are under control, we can deal with them. We think that it's very important to explain this to the patient. So to explain this is a case number one. 71-year-old gentleman suffering from diabetic polyneuropathy since 5 years. عنده سكري وعنده اعتلال عصبي من السكري مدة 5 سنوات. He was diagnosed and confirmed. So عارفين إنه تشخيصه خالص وتمام. He was treated by multimodal approach, including exercising, شجعنا على الحركة وعلى المشي, glycemic control, and good sleep hygiene. And good sleep hygiene is a very important point also to mention and to teach the patient. He was started on pregabalin, 75 milligram BID in 2015. He has regular checkups for kidney function, very minimal weight gain, ما كان عنده زيادة في الوزن, and no dizziness declared from the patient. 5 years later, he's still on same regimen. Stable and pain relief is reasonable. He consulted me last week وسألني سؤال شوي محرج. He read about potential abuse of pregabalin and wanted more clarification. So what is your reaction? I put this question just to initiate some sort of discussion or interaction with the audience, but since we can have only questions at the end, it's fine. I'm gonna go ahead. So this patient came to me with this question. سألني هل يمكن يصير أنا يكون عندي يعني مشكلة مع الأدوية اللي أنا باخدها. I explained that he has this medication for 5 years and he is stable on that, and his pain is stable and pain is controlled. At the same time, he has no side effects. The side effects are controllable. His weight gain is under control, no dizziness, no problem. The kidney function is stable. So There's no reason for having any issue for that, and no reason to be scared of this medication. The case number 2 is a young patient, 25 years old. He had car accident in 2018, and he had spine surgery with fixation. Post-operative complication، صار عنده مشاكل بعد العملية، بعد حادث سيارة. بعد ما عملوا له عملية في ظهره صار حادث سيارة وعملوا له عملية، وكان عنده مشاكل في ظهره بعد العملية، التهابات، وكان عنده severe pain، ألم شديد جدا بعد العملية. طلع من المستشفى. He was discharged from the hospital 1 month later with prescription of tramadol and pregabalin. Follow-ups in the pain clinic with recurrent refills, always coming to the clinic having the same medications and refills. And then he started having requests for sick leaves and medical reports, recently asking to increase tramadol and pregabalin, and became very aggressive during his visit, and complains to patients' experience office, claiming that he's having more and more pain and doctors are not giving him medication or giving him other options. These other options have been refused, and patient was not keen to have any other alternative of his medication. So my question again, to stimulate the interaction, what do you think? We have 2 types of patients. We have 2 different personalities. One is elderly man, very stable, very reasonable guy. The second one is young chap. He's unfortunate. He had an accident. This is not his fault, but he has an accident and complication after surgery. So the profile of these patients are different. And the medications almost similar, pregabalin, but the way the patient in the second case was treated and was, between brackets, neglected, and the treatment and the follow-ups with many refills, refill and after refill, without any follow-up and thinking about the balance between the efficacy that we were talking about in the beginning and the side effects. So the next one is, I wanted to introduce the classification for control medication, and this is a very interesting point. We need to know that we have schedule. We have 1, 2, 3, 4, and 5, and this is the US system where you have, according to the severity or the importance of the medication, we have to schedule them 1, for example, for anything like heroin, schedule 2 like oxycodone, fentanyl, schedule 3 like buprenorphine, schedule 4 is like all the benzos, and schedule 5 is medication that is with very, very low risk of abuse. And what's the abuse potential for our patients? It's reversed to the direct potential to be used in non-medical situation, repeatedly or even sporadically, for the psychoactive effect it produces. So we have an example of some psychoactive effect, including sedation, euphoria. المريض بحس بهيك بنوع من الطيران، انه يكون حس مبسوط. Mood changes and cognitive distortion. And the drugs with abuse potential mostly produce psychic and physical dependence withdrawal, and may lead to disorder of addiction. ممكن الدواء نفسه هو يكون له عوامل أو آثار جانبية توصل للتعود، وتوصل لحالات الانسحاب اللي تصير معهم الحياة. So مش بس personality, the medication itself can be one of the reasons for that. So the substance use disorder, we have 5 categories. The first one is that abuse. Now we're not talking about abuse. We talk about substance use disorder. So تغيرات في استعمال الأدوية. مش abuse or مثلا addiction. لا, substance use disorder. So the first one is misuse. So any use of prescription medication beyond what is directed in a prescription. So this is a misuse. The tolerance, when patient is starting to escalate and to ask for more dosing and telling you that he's not feeling enough pain relief, so he's thinking that maybe increasing the dose is better. And then we start having what we call dependence. And this is a state associated with withdrawal symptoms. حالات انسحاب، المريض بحس حاله تعبان، بيعرق، بيبرد، بيصير عنده حالات أرق. هالأشياء هذه سموها هي withdrawal symptoms. اوكي، على أقل حالة توقيف للدواء. Whenever we think about stopping, patient will have these withdrawal symptoms. And then we'll have addiction. Patient cannot tolerate any changes in his regimen, and he needs to have his medication. He starts to be aggressive. مريض بيصير حالة عصبية، بيصير aggressive and trying to get his medication for any price. And then we have the diversion, where patient is using the medication for non-medical and for some financial purposes. These are the 5 steps of that. So, as I said at the beginning, we had the personality, all the biological, psychological, and socio-economic environment factors. كل الأشياء اللي تخص الشخصية، وفي أشياء تخص الدواء نفسه. ممكن يكون عندك دواء ما له أي علاقة بالأدكشن، لكن شخصية المريض بتخليه يفكر إنه هذا الدواء هو الحل الوحيد، فبصير addicted للدواء هذا. هذه شخصية المريض بتقرر. في أدوية they have reasons, and these medications, they are medications which can lead to some tolerance, some addiction, and we'll talk about them later. And these medications will lead to some changes in the brain neuroplasticity. So الأدوية هذه بتغير المستقبلات، the receptors الموجودين في البرين، فبتوصل لحالات الادكشن في بعض الحالات. وفي كثير أشياء في البرين، في سيركوت مثل الحلقات متعددة وعارفينها نحن. The glutamate, the GABAergic receptors, acetylcholine receptors, and dopamine receptors and circuits are important, and they can lead to this vicious circle of getting medication, getting rewarded, and then having tolerance addiction later. The first example of this risk is the opioids. Everybody is talking about opioids, how to control opioids. So opioid dependence versus chronic opioid dependence versus chronic pain managed with opioids. The diagnosis of opioid dependence requires 3 or more criteria occurring over 12 months. The first one is tolerance. Patient will ask you to add and to increase the dose. Second thing, if you do any stopping or cessation of the medication, he's starting to have withdrawal, physical dependence. These are 2 important points. And then we have maybes. Maybes means medication taken in larger amount or over longer periods, unsuccessful effort to cut down and to taper down the medication. إنه صعب إنه ننزل الميديكيشن لأنه مريض اتعود. And great deal of time spent to obtain substance. They go shopping around. They can ask for different areas to get the medications, and they have hard time to reduce, and they continue use despite harm, even if they are not in a good shape. So we have criteria to tell that this patient is addict and can have risk of addiction. The other example is gabapentinoids. Everybody is talking since maybe 4 years about gabapentinoids. When you look at the pathophysiology and the receptor point of view, there is nothing in this family which can be explained or can explain the addiction. There's no circuit like for dopamine, like for acetylcholine, or for mu receptors, nothing. We'll see the receptors later. But there are some restrictions from some countries in order to be on the safe side. But the WHO and the gabapentinoid has not been reviewed, but has not been scheduled, and they remain under surveillance only. So they need to be under control. They need to be seen by patients. They need to be seen on a regular basis, but they're not scheduled as we think Schedule 1 to 5. From the beginning, this medication was Scheduled 5 in the US, which means very low risk of tolerance. In the UK recently, in October 2018, they started to have this kind of surveillance and audits about this medication in order to understand what's going on. And again, there's nothing to explain, but when you come back to this psychosocial biosocial model, we know that the personality will be very, very important point. For example, these two cases that I present, the diabetic polyneuropathy and the postoperative or post-laminectomy syndrome, they're having the same medication, but this medication was not an issue for the first case, but an issue for the second case. There are many receptors involved, and we know that the cannabinoids receptors, we know the anything related to what we call NMDA receptors and methyl D-aspartate receptors, like for ketamine, for example. Then we have the dopamine receptors and dopamine circuit. We have the mu agonists or the opioids. We have also the alcohol and all these kind of the GABAergic, benzodiazepine, nicotine can be one of the addictive tolerant circuit also. And as you can see here, pregabalin activity is not existing on all the receptors, and that's what I was explaining, that we don't have any reason thinking that these medication can be an issue. And just to explain that in more clear way, these calcium channel modulator, we call them, are acting on specific calcium channel, which will modulate and moderate the influx. You can see here the influx or the entrance of the calcium channel into the presynaptic junction here, presynaptic here, and reducing the hypersensitization of the junction the neural side. So we think that this calcium channel is not an issue for tolerance. Again, we need to put real importance to the personality and the environment of the patients. In 2014, there was, as I said, starting to have like assessment committee regarding the abuse and dependence of these medications, and they were updated from potential to identified risk in the risk management plan. So that was based on post-marketing reports. And then in 2018, the WHO Expert Committee or Drug Dependence Critical Review has rated that the rate of abuse of pregabalin was low, and the pattern of reported pregabalin abuse varied by country. So there are, again, when we talk about countries, that means maybe personality issues and personality will be more influential on this subject. In 2019, the pregabalin was put under surveillance, and the medicine is not recommended for scheduling at this time by the WHO. They were very clear on this statement. So the only thing when we talk about medications and talk about misuse or proper use, we need to integrate everything in like a treatment plan, in the pathway, clinical pathways. We shouldn't forget the personality and the environment of the patient. We shouldn't forget also the medication itself, which can be one of the risk factors for to patient to go for addiction or tolerance. And we need to think about multidisciplinary approach. We shouldn't be like a one-man show telling everyone that we can manage. The expectation of the patient should be always taking into consideration. We think that by reducing or tapering down the expectation of the patient, we can deal better with medication that can be taken on the long run with some potential tolerance or addiction risk. So that's my view on that. And to finish my presentation, I always think that the pain pathways and the pain clinical pathways should be integrated within regimen, which leads to many sort of puzzle. In the middle, we have the pharmacotherapy here, which is an important part. But of course, physical therapy, sleep hygiene, as I said at the beginning with the case number 1, the lifestyle management, the stress management, interventional pain management, which was offered to the second case with, for example, we could have done for him a spinal cord stimulation, and this post-laminectomy syndrome could have been solved without any problem, and patient who could have been treated without any risk of tolerance. Any other alternative non-pharmacological medicine is important with biofeedback. Cognitive behavior therapy can be also an important point. Occupational therapy, our friends from occupational therapy can have a good impact, positive impact on these patients. And at the end here, the education is an important point, and we need to always spend some time with education. And in my current hospital, we calculate the time and we document the time spent with the patient to educate them about the pathology, about the pain, about the side effects of medication, about the efficacy of these medications. So it's very important to have this kind of explanation to the patient to be on the safe side and to have this confidence and this trust between patient and the healthcare provider. And at the end, I started with pain pathways with my university in Paris, René Descartes. He had a very interesting pain pathways that has been described and developed later on. But my last slide will be on the pain pathway, different pain pathway. This is my slide. I took this slide in Al-Quds, where we have Via Dolorosa, Tariq al-Alam, where the Christ went from a place to another in Jerusalem, in Al-Quds, in Palestine. Thank you for your attention. I will be glad to listen to all your questions.
Thank you very much, Dr. Ammar, for the very interesting, educational, and informative lecture about pain and pain meds, proper use versus misuse. So I'd like to start off the floor with a question that I routinely face with sometimes in clinic, is that I guess pain and pain management is every person's different, meaning that, you know, what may work for one person may not work for someone else. And it's not exactly a one size fit all type of treatment. Would you say so?
Absolutely. It's 100% true. Patients are different. The way they receive the information from us when we talk about any pathology is different. The way their expectation is different, and it's all about their environment, their background, if they're educated, إذا هم متعلمين, إذا في عندهم قرأوا. We're having more and more patients very informed, but the problem with Google, Dr. Google is sometimes a problem, because you have many sources, and these sources sometimes are not very reliable. But we need to always think about taking time to educate, taking time to change their beliefs if needed. So I agree with you, patients are different, and our approach to them should be tailored according to their personalities.
Thank you. Would you say that in regards to pain management, is that, and the one thing that routinely I notice, and I have medical students and residents that rotate with me on my neurology, for a month of neurology, and it's not uncommon that, you know, sometimes, you know, I'll have patients come to my office, little old lady, you know, she, like your second case, she had a spinal cord injury, but she's on pain meds, you know, multiple pain medications, but I've known her for 5 years. There's never been any interest. There's never been any abusive potential to her medications. I see her every month. She comes every 30 days as prescribed. She takes her medicine and she comes back 30 days later. And to me, she's interacting well with her surroundings. She's interacting with her family. So one thing I commonly see with residents is that they worry about, well, what if she gets addicted? Is that the end result of pain medicine per se? Is that you will be addicted if you take these medications, or is it's a balance between what works and what helps?
Yeah, as you said, her personality and her environment is very important. So she's supported. This lady is supported by you as a physician, supported by the family, and her personality is with the good result and good outcome for her medication and her treatment plan. So we are safe. The channels are very safe. We're not jumping from one side to another. We're really going in the right pathway, clinical pathway. This is a typical patient that comes, as you said, on time, not coming earlier to get more medication. By the way, now, if they come earlier, there is a system now in UAE which really did great job. The system is amazing, where you can see exactly what's going on. If patients are shopping, you know them, and this helped us a lot in order to manage and to control these kind of patients willing to get more medication from different places. So your patient, great, and there's no harm in continuing on that, monitoring her vitals, monitoring her kidney function, liver function, and be safe. Yes.
Thank you. Looks like we have a lot of questions. It's been a lively webinar. Multiple questions appear to be posted. Gerard, I will leave the Q&A for you now.
Thank you. Thank you, Dr. Ammar. Yes, indeed. Thank you very much for a very interactive and entertaining lecture. We've had many questions posted on the public chat, and also, as you can imagine, on the private chat as well. So I will just start with some in the remaining 20 minutes that we have. The first question we received is, this person, they have a condition that requires multiple pills, and pain pills, when they take them, cause them issues when with the medications. What advice do you give to them? What can they do in the next steps to help overcome this?
It doesn't say what issues. What is the issue with the medication?
That's all the information we have from this question.
Mm-hmm. If issues means side effects, then we know how to deal with side effects of medications. If they have interaction between medication from different families and different molecules can interact, this is also can be manageable. If they have issue, and if I understand issue as a tolerance, then we need to revise our discussion and our plan with the patient. We need to talk again about the pathophysiology, about what is pain medication, explain exactly the receptors where these medications are acting, and try to, again, as I said, tailor our scientific language to their need. And then, if I understood well this question, I mean, trying to get all the aspects of this question.
Yes, absolutely. Thank you. I know we don't have enough information to give an appropriate answer, so thank you for giving that. Next question is, this person has been using pain meds for a long time, but they say they hate the withdrawals. Do you have any advice about what can help?
They hate the
withdrawals.
Withdrawals?
Withdrawals?
Yes.
Yeah, I mean,
what can help? Do you have any advice from that to help with those state withdrawals?
Withdrawals is a very serious situation where we need to think about medications. We have alternatives to medication. Sometimes we need to admit patients to trying to taper down and avoid these withdrawal symptoms, because withdrawal can lead to very, very serious situation where patients will be aggressive and they can be very harmful to the environment. So we need to be careful about these things. So, but I don't think if patient is feeling that withdrawal is coming, that means, or feeling withdrawal from his medication, that means his situation is not under control from his physician. He needs to consult as early as possible, and trying to see if they have alternative for his medication, or adding other medication that can help reducing the withdrawal. So this is a serious situation, withdrawal. Yeah.
Thank you. Okay. The next question is a private question. I believe it's come from a healthcare professional. They say, how to detect when a patient is dependent versus addicted on pain medication?
Very good question. I like the question. So, patient is addicted. Chronic pain patients, we know them for many years, or many months. We know these patients. We know their personalities. We know how, or we can see how they deal with our discussion, and how they are convinced with our explanation regarding their pain and their pain medication and the expectation for their pain medication. When they start to be dependent, that means there's a link which is missing here. That means something they did not understand. Dependent because the pathology is not well treated. Injection maybe can be one of the options, but was not proposed to the patient. And many centers around the world, not only in UAE, they don't have interventional pain physicians. They don't have interventions, and this is another issue. Maybe the patient has not been through psychologists to help them coping with their situation. So many situations that can block and that can prevent this dependency from reaching this situation. Addiction, when patients started to be addicted, that means we need a rehab center, complete different setup. Addiction and diversion means we are in the pathological situation where very strong action should be taken. These patients should be admitted. They should be with the regimen of de-escalation of their medication, and there are alternatives to help with withdrawal and reducing their doses in order to help with their dependence and addiction.
Thank you very much for that excellent answer. Another private question that came in was the discussion about alternative therapies, or your advice or experience in advising on alternative pathways or alternative therapies to traditional pain medications. Do you have any feedback for us on this?
Yeah, my first slide was focusing on the psychosocial and biological triad, because the multidisciplinary approach is very important. We cannot treat a patient with chronic pain patient, without having the help of neurologists, sometimes neurosurgeon, psychologist, physical rehab. So it's multidisciplinary, focusing on the quality of life. If I need to help my patient with a cognitive behavioral therapist, for example, I know that we can help him in how to cope with medication, how to cope with his situation, how to improve his mood status, and this is very important. The sleep hygiene is also an important point to cope and to help and to advise the patient. Advise our patient, because sleeping well means regeneration, means patient will be in better mood, and will be less anxious, and there will be less pain with that. So we can go up to 20-30% of reduction of their pain scores or pain situation if we use these alternative medicine. Physical therapy is an important point. I call it balanced physical therapy, or monitored physical therapy, where we do blocks, for example, to help them having active physiotherapy. So this is also an important point with these alternative methods for pain management.
One thing also I'd like to comment is that in the last lecture we had Dr. Osama from Imperial College talk about diabetic neuropathy. And even sometimes treating the underlying cause is also important. It's not just about the matter of like, just give me a pill to take the pain away. It's find the underlying etiology to why you're in pain.
Exactly.
You had mentioned that.
Exactly, yes. Exactly. For the first case, for example, glycemic control is one of the most important point for this patient to be safe. He's safe. He's stable because he's controlling everything. He's controlling his sleep, his environment, as you said, Doctor. The environment, the family around, and is very important. Yes.
Thank you. Thank you, Dr. Ammar. Next question, again, is my family are scared as I'm taking pain medication. What should I tell them? They're saying it's beginning to change me.
Yeah, this is a very interesting comment, and we have these kind of discussions about pain medication with families coming with their kids, and this is important for them to have these medications. So we explain them. These medications under control. This is an important message they need to listen to. These medications are under control, and this is not a treatment for life. Sometimes we need to have strong medications for a certain period of time to help patients bypassing difficult situation, waiting for spinal cord stimulation or waiting for interventional pain management. We can increase the dose under control and reduce them later. So, for example, we need active physiotherapy for 2 weeks, 3 weeks. So these medication can be escalated up and down according to this. So it's tailored according to the patient, tailored according to the pathology itself, treating the cause, Dr. Shatila said, and explain to them that these medications are only there for help, not to be a burden for them and for their life.
Okay. Thank you. Next question, I believe, is from a healthcare professional. They are just wondering if you're using any placebos here in the UAE when managing chronic pain for patients.
No. I've never used a placebo.
No comment.
Okay.
It's unethical, first. It's not the way to do. It's not for chronic pain patients. Chronic pain patients, if they have medications, they know if this is placebo or not. So it's not in UAE. It shouldn't be a way of treating patients. This is disrespect of patients if you use placebo for chronic pain patients. Sorry for.
Thank you. The next question, you've touched on it a number of times. We've had a number of private questions regarding mental health advice and when to seek mental health. Can you just maybe expand a bit on that? Because some people say they're suffering some mental health issues when taking them. When do you advise them to go and see a mental health specialist?
Yes. It's not a bad thing to see a mental health. Some patients, they said, "Oh no, I'm not a psych. I'm not psycho. I'm not going to go and see any psychiatrist or psychologist." Or it's I always my last slide is like puzzles. It was animated puzzles, but it came like this, no problem. But these are like links. If, for example, the physiotherapy is helping 10%, the interventional pain medicine is helping till 50%. The mental health specialist or any support from our colleagues, psychologists or psychiatrists, is also an addition to our multidisciplinary approach. When we do that, it's always important to do it early as possible, explaining the patient that they need to think it's only for specific questions.
Looks like internet froze.
Yeah. I believe Dr. Ammar's internet has frozen.
Okay.
I believe he may be able to come back shortly. Dr. Ammar?
Yeah.
I'm not sure. Maybe.
Any questions, Gerard, that I can answer in the meantime?
Exactly, Doctor. Yes. There's a question here regarding this person when taking pain medication. They're beginning to gain weight and feel exhausted. Is this a common sign of pain, or is it something else related to the pain medication?
Well, the way I would usually approach, looks like we lost Dr. Ahmed. Hopefully he can rejoin us. In regards to side effects, so weight gain and feeling exhaustion can be a side effect of certain pain medications. It looks like we're back. It may be a side effect of certain pain medications, and if that is so, what I would recommend is first review your pain. What's the pain medications that actually review all the medications that you are taking with a physician and determine what may or may not be related or caused by the medication and what may be due to extraneous causes.
Thank you very much. I think Dr. Ammar is.
I can answer some private questions.
Can you hear me?
Yes, we lost you for a second.
Okay.
Yes, yeah, no problem. No problem. Thank you for Dr. Ahmed filled in extremely well for you in the few moments.
I tried my best. Here's one question I received in private, Gerard. It's kind of pertinent, but not pertinent to where in the region of the world we live in. What is the role of the psychiatrist for these patients? But what do you say about cannabinoids for neuropathic pain? And I can at least comment, I think psychiatry is a more, as you had mentioned, pain or a pain specialty clinic is not just one physician, it's a team of physicians. In regards to cannabinoids, there have been some studies in regards to MS care that cannabinoids and actually it's either activating or potentiating cannabinoid receptors may show some effect, but as of now, this is not a treatment that is available in this portion of the world. So for all intents and purposes, it doesn't exist, so I don't usually comment further about it.
Yeah, I agree with you. There's no reason and there's no space for the cannabinoids for neuropathic pain. I can refer you to our publication for the Middle East guidelines for neuropathic pain, and you have first, second, and third line for neuropathic pain treatment. So you can see that even in the Canadian American Society, now a third line for neuropathic pain, not the first, not the second.
Exactly, I agree with that. Another question is, what is the best pain management for shingles infection, and how long can be taken safely for a 60-year-old asthmatic female?
For 60-year-old?
60-year-old asthmatic female.
Okay. For shingles or post-hepatic neuralgia, we have many options. We have the topical option, which is the capsaicin patch, which targets the TRPV1 receptors on the nerve endings. It works as defunctionalization of the nerve endings with the area where the area is painful area. This is the first one. The second one, since I'm very interventionist, we do lots of paravertebral blocks. If it's thoracic, if it's, for example, in the face, we do a trigeminal ganglion block. We do lots of radio frequency ablation of the Gasserian ganglion. And in addition to that, we have the antineuralgics, the pure analgesics. Pregabalin, for example, can be an option. I'm using more and more buprenorphine patches for my patients with this kind of pathologies, and it works very well.
I've received a private message from a physician. It appears to be a comment, but there may be a question in the comment. pain threshold is usually high in neuropathic or organic cause, so addiction is unlikely. What say you about this comment? Do you agree or disagree?
The pain threshold is high in neuropathic?
Yes, it says pain threshold is usually high in neuropathic pain or organic causes, so it's unlikely to be addicted. Would you agree with?
We have lots of neuropathic pain with low back pain, simple low back pain. They get tolerance from many medications, and they can jump to addiction. There's nothing in the literature showing or talking about threshold for neuropathy. There's no threshold for neuropathy. There's pain and there's pathology itself, but I can't answer this question in telling yes or no. But in the literature, as far as I know, there's nothing related from neuropathy or any neuropathic pain with threshold. The threshold is something related to the personality, to the person itself, not to the pathology. The pathology is there and the burden on the body is there, but the threshold has nothing to do with the pathology itself. It's the personality per se.
Got it. Thank you.
There's a question coming here. We only have a few moments left, so we'll try and get through as many in the last 2 or 3 minutes.
Okay.
There's so many. Thank you so many. We could go all night, but I know Dr. Ammar is a very busy man. So the next question is: am I recently diagnosed? I was recently diagnosed with peripheral neuropathy. Is taking pregabalin safe?
What kind of peripheral neuropathy? Is it entrapment?
Lost Dr. Ammar again.
Seems as though we've lost Dr. Ammar again at the final.
I guess I may try to comment, is it safe? It is safe, but it is also important to be monitored and followed with a physician. At the end of the day, any medication can have side effects, wanted or unwanted side effects that we can see, unwanted side effects that may cause trouble. So it's important to make sure that you follow with a physician, a neurologist, a pain specialist. So is it safe? Yes, it is safe, but it is important to make sure that the dose is being monitored, make sure there's no other comorbid conditions that may affect your ability to take this medication.
Yes, absolutely. I think we've reached the hour. Yeah, it's unfortunate. We do apologize. Dr. Ahmed's internet connection, the final few moments seems to have failed him, but if he does join back in the next couple of moments, we will welcome him back. Just to announce that this webinar has been recorded and will be available for 4 days after the event has finished. We will be sending a recording of this out tomorrow, tonight, and also tomorrow. This was the final lecture in a 3-part series that was supported by SSMC and by Saha, and also to Pfizer Upjohn. And it's Dr. Ammar, you're back.
Can you hear me?
Yeah,
I can hear you. I'm hearing you all the way. I don't know why.
Excellent. You froze up a bit, but welcome back.
Again, yeah, unfortunately, the issue.
Yeah, I heard the answer of Dr. Shatila about the peripheral neuropathy. I agree 100%. Pregabalin is safe not only for peripheral neuropathy, also for central neuropathies, like for CVAs, like spinal cord injuries, lots of indication for that. But as you said, monitoring is a very important point. And peripheral neuropathy can be lots of diagnosis for that. It can be nerve entrapment. So we need to think about treating the cause along with giving medication. So important to treat the cause also, the underlying cause.
Excellent. Thank you.
Thank
to
you.
fill in your shoes. Big
Thank
shoes to fill.
Thank you, Dr. Ammar. Thank you for that. Thank you for joining us for an amazing presentation. And we had over 250 people
Oh my God! Oh,
today,
nice.
and I'm sure.
Congratulations, guys. Very nice.
And I'm sure a large number will watch
Thank
it on the replay. As I mentioned before, this webinar has been recorded and will be live for the next 4 days, so people that have missed it can watch it again. I will pass you back now to Dr. Ahmed and Dr. Ammar for the final closing comments before we end the webinar.
Dr. Ammar, if you have any closing statement that you would like to...
Yeah, I just encourage you to read and to connect with physicians that help with pain patients. They are not easy to manage sometimes. Do not hesitate. It's not a shame that you ask referrals and to ask for a second opinion. It's good to interact and to have collaboration with different disciplines.
Thank you very much. Honestly, thank you very much for the very educational and informative lecture. I learned a couple things myself. Well, I always look forward to these because you always learn. You never know. You can never say I know too much. Exactly. So thank you so much for this lecture. I'd like to just end the webinar with the idea that if you are suffering from chronic pain, the most important thing is to have you have to have a level of relationship with your physician. It's a two-way street. You have to be able to trust your physician, and your physician should be able to trust you. And I think that is the essence of medicine. And once that relationship is established, hopefully, we can try to manage the pain, control the pain, and at the end of the day, to help these people live a better life. And I would like to end this webinar with just thanking our sponsors, Pfizer Upjohn. I would like to thank SSMC for sponsoring this event, for hosting this event, and Gerard from Focus Golf for hosting the event. And then finally, Dr. Ammar Salti, again, thank you very much for giving us teaching us today about chronic pain, use versus misuse. Much appreciated. And with that, thank you very much, and good night, everyone.
Thank you, Dr. Ammar Shatila, for moderating these last 3 webinars. This was the final webinar in a 3-part series. They will be available very shortly on a dedicated website, which will be launching free for all the public. That will be announced very soon. But until then, we'd like to thank you all for joining us, and we're wishing you all good night. Thank you, Dr. Ammar, and thank you, Dr. Ahmed.
Thank you. Bye-bye.